Dr. Fida Bacha is graduated from American University of the Beirut Faculty of Medicine in 1995. She works in Houston for as well as 5 other locations and specialized in diabetes, endocrinology, metabolism, diabetes and metabolism, internal medicine, pediatrics, and pediatric endocrinology. She is affiliated with Texas Children's Hospital and Harris County Psychiatric Center. She will be speaking on approach to type 2 diabetes younger than 25 years. So over to Dr. Fida for this talk.
Thank you. Good morning, everyone, and thanks for being here. Good evening to you in India. I am pleased to be presenting today on the approach to type 2 diabetes in youth younger than 25 years of age. What's the evidence so far? We will start with talking a little bit about the epidemiology of youth diabetes, the pathophysiology, and present to you data regarding the high prevalence and rapid progression of cardiovascular disease risk factors in adolescents and young adults with diabetes. And then we'll tackle the approach to therapy with the evidence available to date. As probably has been presented in this meeting, type 2 diabetes is a major global health burden, with 463 million adults living with diabetes in 2019, 90% of whom had type 2 diabetes. An additional 374 million are living with impaired glucose tolerance, and that signifies a significant increase in risk for comorbidities in these individuals who do not know that they have diabetes. Already, the numbers of individuals with diabetes has surpassed any previous expectations. And right now, IDF, the International Diabetes Foundation, estimates that 578 million adults will be living with diabetes by 2030 and 700 million by 2045. In Southeast Asia, the picture is similarly concerning, with 1 in 11 adults having diabetes, and 1 in 5 people with diabetes in the world come from Southeast Asia, but 1 in 6 come from India. And about 1 in 4 live births are expected to be affected by hyperglycemia in pregnancy. This is particularly alarming to us in pediatrics, as it signifies significant increased risk for future comorbidities, particularly type 2 diabetes early in youth. The incidence of type 2 diabetes has been going up. This is data from the Search for Diabetes in Youth study from the US, showing about a 7.1% increase per year, with some variability according to race, ethnicity being highest in Native American and then in non-Hispanic Black youth. And not surprisingly, these latest data now from the Search study show the increased prevalence of youth type 2 diabetes between age 10 to 19 over the past 16 years, up to 0.67 per 1,000 youth in 2017. This is an absolute increase of 0.32 per 1,000 youth, with a 95.3% relative increase over 16 years. And the data are not so clear in South Asian youth. UK data that evaluated individuals between 0 and 29 years indicated no significant difference in incidence per 100,000 person years between non-Asians and South Asians. However, as you can appreciate here, type 1 diabetes was going down in South Asians, whereas type 2 diabetes was increased by 3-fold between 1990 and 2005. Recent data that compared Search to youth diabetes registry in New Delhi and Chennai regions in those less than 20 revealed that the incidence of type 2 continues to be higher across both sex and all age groups in the Search study. But what we can appreciate, there are some differences between the two registries. Research is more population related. The Indian data is more center related. And so maybe there is some ascertainment difference there. And also there was similar incidence of both in both females and males in India versus a greater proportion of females affected in the US data and younger age of onset and search. And so these data suggest that type 2 diabetes may be occurring earlier in children in the Western hemisphere, likely related to a more obesogenic environment. We will see what the future brings nowadays, with also seeing increased rates of obesity, particularly in relation to the COVID-19 pandemic. Youth type 2 diabetes is different from adult. I think we have seen a lot of data come up recently that supports this. When we were evaluating pathophysiology, and there were no direct comparisons between youth and adults until the recent restored insulin secretion study, or RISE. In our center in Pittsburgh, where I was previously, we had evaluated youth with early onset pre-diabetes, compared them to adults of similar percent body fat and hemoglobin A1C. And what we found is that youth had about 50% lower both peripheral and hepatic insulin sensitivity compared to adult of similar BMI, percent fat, and hemoglobin A1C. This was later verified recently in the RISE study, with again RISE showing about 46% lower insulin sensitivity in youth with early type 2 diabetes or prediabetes compared to adults at similar body composition, at similar BMI. And another feature of youth type 2 diabetes different from adult is that there is hypersecretion of insulin. This is data from RISE. And what you can see at every level of insulin sensitivity, the youth here in red compared to the adults in blue have a hypersecretion of insulin for their insulin sensitivity about 2-3-fold. We don't know the significance long-term of this finding, but it can indicate perhaps that there's hypersecretion may eventually lead to more rapid beta cell failure. This remains to be seen. In our studies also of type 2 diabetes youth compared to obese controls of similar BMI, sex, race, ethnicity, very early on, we demonstrated type 2 diabetes youth have about 50% lower insulin sensitivity compared to their obese counterpart. We also showed that type 2 diabetes at presentation in childhood is already associated with about 50% lower insulin secretion compared to non-diabetic controls. And so when you look at the glucose disposition index, which evaluates insulin secretion for the degree of insulin resistance, youth with type 2 diabetes have about 85% lower glucose disposition index. Therefore, these youth are already presenting early in their diabetes within the first year with severe beta cell dysfunction. And therefore, when we evaluated the response to therapy in youth as part of the treatment options for type 2 diabetes in adolescents and youth, or today's study, what we can see is that when these youth were randomized to 3 treatment arms, metformin plus rosiglitazone, metformin plus lifestyle, and metformin alone. These were the agents that were available for treatment of type 2 diabetes in youth at the time of the design of the study in the early 2010, 2011. And what we saw in today is that there was a loss of glycemic control on assigned medical therapy in about 50% of these youth. Those on metformin and rosi did a bit better than those on metformin alone, with no significant difference between those on metformin plus lifestyle versus metformin. So with keeping in mind this beta cell dysfunction I talked about, this means this again adds to the picture of severity of youth diabetes, as this rapid loss and non-response to oral medications is much higher than what we see in adult studies of similar design. And what this also suggested is that about 50% may have durable control on metformin alone. The addition of another agent may be needed early on in the process. Metformin plus lifestyle did no better than metformin, unfortunately, in this group. And again, when we evaluated the data in today, compared to our youth clamp data that looked longitudinally at beta cell function, what we found is there is rapid decline in beta cell function over time, with about 20% decline, whether you look at it clamp or with the insulin-genic index in the Today study, versus the lower progression in adults, about 7% using HOMA percent beta in the UK PDS, and about 10% per year in adopt a similarly designed study similar to Today. That also verified that these youth are rapidly progressing in beta cell function deterioration. Other findings that we could gather from today is that, again, metformin can be effective in those with the type 2 diabetes less than a year duration, and about 50% responded long-term. Early addition of second agent, as I said, and we also saw some racial ethnic differences in treatment response, greater failure among non-Hispanic Black youth, and some sex differences as well. An important take-home message also from today is that when we looked at durability of glycemic control at 48 months in Today, the baseline hemoglobin A1C and insulin-genic index at randomization in the study were determinants of how long someone continued to do well on metformin. And we saw that also in registry data from the Pediatric Diabetes Consortium. And what A1C level may help us predict who's going to respond. Again, looking at data from today, we saw that the ROC curve indicated that the hemoglobin A1C of 6.3% after a few months on treatment, about 3 to 4 months, may be the optimal cutoff for correctly predicting who's going to lose glycemic control on metformin. Also, a rapid increase in hemoglobin A1C by about 0.5 over any period of time, also concerning for loss of glycemic control on metformin. So therefore, if your patient is not reaching this kind of reduction in hemoglobin A1C early on in their course, then you have to intensify lifestyle, intensify your metformin dose, and consider additional therapy until we meet A1C targets. We also learned from today that these youth have a high prevalence of cardiovascular comorbidities, with hypertension increasing from 11% at prevalence at randomization up to about a third having hypertension by the end of the study over 3.9 years of follow-up. We saw a microalbuminuria again tripled. Dyslipidemia doubled in these youth, despite that we initiated adjunct therapies to treat these comorbidities, and we saw at the end of the study about 13.7% had started developing retinopathy. And this is the most recent data that we just published from the Today study, looking at long-term follow-up. After Today was terminated, we started an observational period and continue following these youth until mean age of 26 years, so early adulthood. And as you can see here, by that time, the cumulative incidence of hypertension was 67.5%, kidney disease 54%, dyslipidemia in 50%, and nerve disease in about a third. And about 60% of these youth had at least one comorbidities, a third had two. And by follow-up 9 years into their follow-up, the cumulative incidence of any microvascular disease was about 50%. It rose to 80% by 15 years. So factors that were driving microvascular complications included race, ethnic minority, an increase in hemoglobin A1C, low insulin sensitivity, hypertension, and dyslipidemia in models adjusted for sex, race, and age randomization. And we also know from other studies as well that in early diabetes diagnosed in young adulthood between 18 to 44 years of age versus older than 45 is associated with significantly higher risk for macrovascular complications compared to the general population. And when you look at the MI risk, about 14-fold higher risk of MI for those diagnosed in younger age compared to about 4-fold higher risk of MI in those diagnosed greater than 45 when in comparison to the non-diabetic population. And mortality is impacted by the age of diagnosis with greater mortality and lower expected mean survival in type 2s of young onset versus non-diabetic controls. Hemoglobin A1C is a major driver for complications, as we all know. So that comes as no surprise, and this has been shown in various populations. However, control of cardiovascular disease risk factors has a significant impact on lowering the risk of cardiovascular events in these intensive glucose lowering trials. So we should not forget about addressing this other need of control of cardiovascular disease risk factor in individuals with diabetes. How about youth type 2 diabetes therapy? What do we have available right now? The challenges, as I mentioned already to you, is that we have to address both insulin resistance and the beta cell dysfunction. And we may have to choose different agents for early onset versus most prolonged duration because of loss of beta cell function. And we have to keep in mind other racial, ethnic differences, sex differences, the CVT profile, and issues with adherence in youth and young adults. The goals is we need to achieve glycemic control, but also avoid excessive weight gain in these overweight and obese youth usually, avoid hypoglycemia, have a long-term favorable CVD outcome, and for young individuals who are usually, typically they have a hard time with maintaining control in this age group, issues of adherence and cost are major as well. So type 2 diabetes therapy needs to be individualized. A glycemic target of less than 7% is reasonable. Diet, exercise, and diabetes education are foundation of the therapy. Metformin continues to be the first-line agent, and insulin may be required to maintain glycemic control. And so keep that in mind very early on. Consider combination therapy and balance the benefit versus the side effects. And we also need to always consider CVD reduction as a focus of our treatment. So metformin, the older drugs that have been available, and until recently only metformin and insulin were approved for type 2 diabetes therapy in individuals younger than 18. Metformin decreased hepatic glucose production, increased muscle glucose uptake. It decreased A1C by about 1 to 2% and has a modest weight reduction effect. We have to be cautious about mild side effects of GI intolerance, and usually adjusting dose helps with that. The thiazolidinediones, PPAR gamma agonists, have been utilized in adults. Mostly we used ROSI in the Today study, and they have significant effect to improve adipogenesis with healthier fat, increase insulin sensitivity, and decrease inflammation. However, they're associated with weight gain, slow onset of action about 2 to 4 months, and fluid retention, edema, risk of fracture long-term, and potential risk of heart failure. So they're not very favorable, and typically we are not recommending them routinely for use in the young population, but that can be individualized. Sulfonylureas have been around for a long time. They lower A1C by 1 to 2%. They have direct action on the pancreatic beta cell, KIR6.2 SIRT1 receptor. However, their effectiveness decreases over time, and they may promote loss of beta cell function. There's increased risk of hypoglycemia and weight gain. In youth, one study did not show a benefit compared to metformin, and therefore we do not recommend sulfonylurea in young population. I should say in less than 18. Insulin should be considered, but has a very favorable effect, as you all know. However, the side effects are hypoglycemia and weight gain, and need for monitoring blood sugars, and therefore we're very happy that the newer agents came along. So in the past several years now, between 1995 and 2010, about 8 new classes of agents became available, and that has advanced therapy significantly in the adult population, with change in our recommendations for initiating a second agent, whether it comes from the ADA or other major national institutions. And I will not go over the details, but for oral agents, we have before inhibitors, bile acid sequestrants, dopamine 2 agonists, and SGLT2 inhibitors. And some of these will be discussed in a little more detail. And for injectables that are non-insulin injectable, we have now the glucagon-like peptide receptor 1 agonist and amylin mimetics. In addition, there's a new oral GLP-1 receptor agonist, semaglutide. Moreover, we are having more newer combination therapies that seem to be very promising. Incretin-based therapy, GLP-1 receptor agonist mimic the endogenous GLP-1. They have effects to increase insulin production in the pancreas, decrease glucagon. They slow down gastric emptying and increase satiety and body weight, reduce body weight through central mechanism. And overall, they would reduce hyperglycemia this way. The dipeptidase 4 inhibitors inhibit the enzyme that DPP4 that degrades GLP-1 in the circulation, and therefore prolong the action of endogenous GLP-1. These medications have shown in several trials that they are very effective for reducing hemoglobin A1C, more so GLP-1 receptors versus DPP4 inhibitors. They reduce blood pressure, have positive effect in reducing triglycerides and LDL cholesterol, increasing HDL. Again, a little more effectiveness seen for the GLP-1 receptors, which are also associated with greater weight loss, about 3 to 4 kilograms, whereas the effect of the DPP4 on weight loss is not that marked. And however, we see an increase in heart rate with the GLP-1 receptor agonist. So these have one of the GLP-1 receptor agonists, liraglutide, became approved for pediatric use by the FDA within the past year. And the approval came after the ELLIPSE trial was done in young individuals average age of 14. 60% are females, significantly obese. Most of them were early in their diabetes, so with a mean duration of 1.9. About 20% were on insulin at randomization in the study. And what ELLIPSE showed is that there was a mean change from baseline of hemoglobin A1C of minus 0.64 at 26 weeks, when the primary outcome was defined, and continued about minus 0.5 at 52 weeks, whereas there is increase in hemoglobin A1C in the placebo group. And therefore, the estimated treatment difference was minus 1.06%, favoring liraglutide. There was some weight loss with the liraglutide, although it did not reach statistical significance. And now we have another agent approved for younger than 18, The exenatide once weekly, again, a recent study, phase 3 was completed, showing that children in the treatment arm had significantly larger mean change in hemoglobin A1C with decrease of minus 0.25% versus increase of 0.45% in the placebo. And this led to approval of this agent in the past few months. So now a lot of drugs, particularly the sodium glucose cotransporter inhibitors, are heavily utilized in adults, and they have shown very promising results. In children, we are undertaking clinical trials, and so we don't have the results yet for these agents. Therefore, we still are not routinely utilizing them, although you can individualize the therapy, particularly in those that are older than 18 in which these agents are approved. Problem with these agents is that they have some side effects of osmotic diuresis, increased genital mycotic infections, and the risk of DKA if there is insulin deficiency. However, they're effective for weight loss and have cardiovascular and renal benefits. So they may be favored for those who have early nephropathy or early or high risk for cardiovascular disease. So these agents have shown safety in major trials that looked at cardiovascular event reduction in adults. So we are more reassured about their use in kids and young adults. And therefore, this brings us to how do we approach right now the youth and the young adult with type 2 diabetes. First, we start at the beginning, when they are presenting to us with new onset diabetes. These were our guidelines from 2018, and a lot has changed since then. But our approach was to recommend that if hemoglobin A1C is less than 8.5% at presentation, we can start lifestyle modifications and start metformin POBID and intensify. If hemoglobin A1C presentation is greater than 8.5%, but no acidosis or ketosis, again, we can consider starting insulin and then escalate depending on response. Metformin should be started and titrated up to 2,000 milligrams. However, if someone presents in acidosis or ketosis, manage the DKA IV insulin until the ketosis acidosis resolves, and then subcutaneous insulin. At presentation, we are recommending pancreatic autoantibodies be checked because we don't want to miss someone with early onset type 1 diabetes brought with an accelerated presentation because of obesity. And therefore, if the antibodies are positive, we continue using insulin. If negative, then continue metformin. Try to wean insulin. If the A1C goal is met, great. If not, consider starting insulin. And now with the GLP-1 receptor agonist being approved, I think it's an option to try these even before insulin. And that's how we are now changing our clinical management. And then always consider other therapies and maybe add a second agent depending on response. So our aim is to rapidly intensify anti-hyperglycemic therapy to maintain glucose targets and individualize based on patient preference, their response to treatment, side effects, tolerability. And keep in mind that insulin may be eventually necessary for many patients. And if they go on insulin, we need to monitor blood glucose. And now we are being able to introduce continuous glucose monitoring for those on multiple daily injections. Address cardiovascular risk and comorbidities by treating these comorbidities according to best recommendations. We use ACE inhibitors, ARBs for nephropathy, treat dyslipidemia for target LDL less than 100, triglycerides less than 50, address hypertension, particularly it's a big risk factor for cardiovascular disease, as has been shown in many studies in adults, address non-alcoholic fatty liver disease, polycystic ovary syndrome and sleep apnea, which are also more common in this population. New agents have definitely started to address the unmet need for better glycemic control in youth, because we have seen, again, in registry data and today, that over time there is poor responsiveness to usual agents, and hemoglobin A1C continues to be high, about 9% or more in individuals that are started on insulin. So these new agents are very promising, and we hope that will change the trajectory of that we have witnessed for type 2 diabetes and address early vascular abnormalities. So I will skip this. We have covered it. In conclusion, youth type 2 diabetes has important unique features with rapid onset and progression of beta cell dysfunction, high prevalence of comorbidities, and often challenging socioeconomic features that we didn't cover today. Multidisciplinary management is essential, and we are very excited about changing the course of this disease with the newer agents and continuing to learn more about diabetes in youth. Thank you for your attention.
Thank you, Dr. Fida, for the wonderful presentations, and we really enjoyed that. As we think about adolescent type 2 diabetes, it is a long-term planning for to live with the diabetes. Is it really safe and good to start with the metformin in adolescent type 2 diabetes, or we should try something else also?
I think we have seen that the metformin is well tolerated. It has a good long-term safety record. In the Today study, we have not encountered major side effects from metformin, really. So I think it's safe to say that it should continue being a first-line agent, and then add newer agents as they become more available and we have more data.
What is your opinion about thiazolidine-diane?
Again, because of the concern for increased risk of fractures in adults, because it's associated with increased weight gain and with a possible increase in heart failure in adults, it has not been popular to use it in youth, despite that we saw a little greater effect in the rosiglitazone arm in Today. So therefore, we're not routinely recommending it. Some, in older adults, maybe some people are using pioglitazone, particularly for fatty liver disease. I mean, that remains an option in that population. They're good medications, except we're concerned about side effects, particularly for bone health and heart-related concerns. So we're not routinely recommending in younger than 18. Although I have to say, in the Today study where we did echocardiography, we did not see echocardiographic changes in relationship to the rosiglitazone, but we did see some, maybe possibly lower bone mineral density, and this is being evaluated more.
I have a question.
Sure.
So if a youth onset diabetic becomes pregnant and is an oral drug already, what would you like to do now?
Great question. We did have young people in Today who got pregnant, and we actually had about 306 pregnancies in Today. And we intensified treatment. We refer them to high-risk OBGYN. Metformin is now more acceptable to use in pregnancy with some concern about for the fetus. But typically, we want to intensify treatment in pregnancy and use insulin. Unfortunately, I have to say, our young mothers in Today had a high risk of complications in their babies, despite receiving very intensive treatment. And I will tell you, there was a greater increase of preterm deliveries, about 23%, compared to reference population of 6.9 to 9.9%. There was increase of SGA, LGA. There was also problem with the infant at birth with increased hypoglycemia, and about a third. We have the increased cardiac anomalies in these babies. About 8.5% had a cardiac anomaly compared to a reference population, usually it's about 1%. And about 12% had other congenital anomalies, again, much higher than reference populations, like around 3%. So it is a major concern. We should advocate really for good glycemic control for these young mothers to prevent complication both for the baby, but also for the mother, because when we saw these mothers back in today, after delivery, those who had gotten pregnant had significant increase in nephropathy compared to those who did not have pregnancies in today. Also they had higher risk of higher prevalence of hypertension and dyslipidemia. Therefore, we need to do more for sure. And this is a very high risk situation.
Thank
May
you.
I ask a question here?
Sure.
Right. So you very elaborately,
Yeah.
very elaborately, you spoke about the different anti-diabetic diabetic drugs to be used. I would like you to share your thoughts on what is the approach to manage the comorbidities like hypertension and dyslipidemia. Is the choice of drugs similar to adults? We don't have much of evidence on these things because most of the evidence is beyond 40 years. And so
Very true. So given that we are seeing in these youth early vascular dysfunction with increased vascular stiffness that I didn't have time to cover today, we're seeing some echocardiographic changes that suggest early diastolic dysfunction and increased rate of heart failure in the future. We are also seeing that these comorbidities increase significantly over time, and we are still trying to understand what causes these increased rates. And therefore, we are recommending aggressive control of comorbidities. We start statins, and we did start statins actually today, and despite that, we saw progression of dyslipidemia and vascular stiffness. So we start statins with a goal LDL less than 100, similar to what we do for type 1 diabetes. We may start also fibrates to control triglycerides to less than 150, in addition to diet, exercise, etc. For microalbuminuria and elevated blood pressure, we recommend ACE inhibitors or ARBs, first-line agent. You can add calcium channel blocker, beta blocker, or what have you, to get to good blood pressure control. These are very important risk factors to cardiovascular disease that we need to control in addition to hemoglobin A1C. So yes, we really are advocating therapy. And I didn't mention about, and today, by the end of the study, when these in young adulthood, and these kids who were diagnosed like average age 13, 14, we saw already 4 MIs, 1 stroke, some individuals with congestive heart failure, and renal failure. So those, we had 17 events in this very young population. So we're really pushing for better management of all cardiovascular comorbidities.
that's quite unfortunate.
Yes.
So, doctor, if you had a choice, a youth would choose type 1 over type 2? As far as
both diseases are very taxing, chronic diseases. There's really no way to choose. I would say though, in directly comparing type 2s versus type 1s at about a similar duration of diabetes, and despite somewhat lower hemoglobin A1C in type 2s, some national data from various places have shown that there is more cardiovascular comorbidity and more concern for poor outcomes in type 2, including these differences in mortality that I've shown. So we need to learn more about what drives this in type 2 versus type 1. And we need, intensification of management in both diseases.
Thank you so much.
Thank you for the question. Thank you.
One more question is there on iPhone? No?
For how long do we need to stop these medications, which includes oral antihyperglycemic agents, statins, and ARBs and ACs before we plan the pregnancy and then put them on alternatives?
Great question, and I do not have a good answer for this. Often they become pregnant while they're on treatment. There's no clear indication to stop the metformin before pregnancy, and we need to manage, their comorbidities during pregnancy. So what we do is refer them to high-risk OB/GYN care, where they're really monitored and the baby's health is assessed longitudinally, aiming at really tight control during pregnancy. And despite that, we see all these problems with the children already. So,
but if you had a choice, how long?
I wouldn't stop the metformin. I would really not. Like if someone is only on metformin and there is not a good indication now, there may be some concern for the baby in recent studies, but it has not been confirmed. Insulin has been around for a long time, and it is safe in pregnancy, and these mothers may be motivated for their child to really achieve good control and support them doing that. More CGM is being used in pregnancy as well to get to appetite control, and a treatment of high blood pressure, etc. We haven't seen increased rate of preeclampsia in today pregnant young females, but that also could be a concern in these individuals.
Can I ask a question? How long do you continue metformin? Do you do it the entire duration of pregnancy, or do you give it only in first trimester? Because of the results, that's been rather controversial about adiposities later and all those things. So
yes,
while the first 3 months are very clear, do you continue them in the second and third trimesters?
We do not manage the pregnant female. They're managed by their OB. I favor using insulin. And however, as I said, many of those individuals have not planned their pregnancy, right? So we may have a lot of them being on metformin throughout their first trimester, but I do agree it seems safer to do insulin, particularly in the first trimester.
Dr. Pida, we are approaching to the time limit, and now we'll have to wrap up. And thanks again for the wonderful talk and illuminating ideas about the management even in pregnancy as well as in adolescent type 2 diabetes. Now over to Neeta Deshpande.
Thank you so much.